Good afternoon. I'm Jonathan Edlow, and this afternoon we're going to talk about reversible cerebral vasoconstriction syndrome. This is a relatively recently recognized condition. We'll talk a little bit about the history in a moment, and it's an important cause of thunderclap headache that anybody in primary care, neurology, emergency medicine, any of the neurosciences really needs to know something about. So what is it? Well, reversible cerebral vasoconstriction syndrome, and I'll be abbreviating RCVS, it's a cerebrovascular condition of unknown etiology, and it's characterized by two things. Clinically, it's characterized by recurrent, severe, sudden onset thunderclap headaches. And radiologically, it's characterized by reversible segmental narrowing of the intracranial arteries, and we'll see some examples of that in a moment. A word about the history. Way back in 1986, so what's that, about 40 years ago, Day and Raskin coined the term thunderclap headache. They had a case report of a 42-year-old woman who came to the emergency department, and in retrospect, she almost certainly had RCVS. She complained that she had this horrible headache that was like a hammer hitting her in the head. Her physical examination showed that she was intact neurologically. She had a brain CT scan, certainly not the quality CT scans that we have nowadays, but her CT was normal. She had a lumbar puncture and her spinal fluid was also normal, and she was discharged home. 5 days later, she came back and she had had two additional severe onset headaches, thunderclap headaches. And this time she underwent a catheter angiography. The angiogram showed diffuse vasospasm that was segmental, and it also showed a 1 centimeter carotid artery aneurysm. Of course, RCVS had not been described at that point in time, and therefore the aneurysm was thought to be the cause of her symptoms and was surgically clipped. And a repeat angiogram done 1 month later was completely normal. This is actually a image from the Day and Raskin report back in 1986. And you can see the arrows show segmental, focal, narrowing. This was the angiogram she had when she came back the second time. A couple years later, Colin Fleming described 4 more patients with what they called reversible cerebral segmental vasoconstriction. And they recognized that there have been other cases reported and different names were used and they were found in different contexts. And therefore, there were all these different etiologic labels. And this is just a list of them from a great review by Anne Ducrot in The Lancet. It was called all these different things. Some people now called it the Coll-Fleming syndrome. In patients that had this postpartum, it was called postpartum angiography. A lot of these patients have a history of migraine, so some called it migraine angiitis or migrainous vasospasm. It was called all sorts of things. In 2007, so fast forward about 20 years, Anish Singhal, who's a cerebrovascular neurologist at Massachusetts General Hospital, he and colleagues, Len Calabrese, proposed that all these various conditions should be subsumed by a common term, reversible cerebral vasoconstriction syndrome, and that's where the term was first used. So we're going to talk a little bit now about thunderclap headache because that's the most common presentation of RCVS. This article by Roberts et al. Was an international registry of over 4,500 emergency department patients with headaches, and 14% of those emergency department headache patients were thought to have a thunderclap headache. The International Headache Society has a definition of thunderclap headache, and there are 4 criteria: severe intensity, abrupt onset, and they specify it reaches peak intensity within a minute. The duration has to be at least 5 minutes, and it's not better explained by some other diagnosis. And the abrupt onset, peaking within a minute, I have a problem with that criterion. And the reason that I have a problem is that in a Canadian study of subarachnoid hemorrhage patients, they looked at, and this was a prospective report, over 2,100 patients who were neurologically intact, and they had a headache peaking within 1 hour. And 132 of those 2,100 or so patients had a subarachnoid hemorrhage. Of those 132, 82% did peak instantly. They would meet the International Headache Society criteria, but almost 20% didn't. 13% peaked between a minute and 59 minutes, and about 5% peaked beyond 60 minutes. So if you strictly use that International Headache Society criterion of peaking with less than 1 minute, I think you're going to miss some serious pathology. And therefore, I don't use that. This is a diagnostic algorithm that I use. We're going to deconstruct it and talk about it a little bit later. It looks very busy, and it is busy, but we'll talk more about how to work through the algorithm shortly. The epidemiology, the female to male ratio ranges anywhere from 2-to-1 to 10-to-1, but it's clear that female sex is a risk factor as compared to male sex. The usual age of these patients is between 40 and 60. The median age is 50, but the reported age range is anywhere as young as 10 years of age to as old as 76 years of age. If you were to look at just the official incidence figures, it's quite low, 0.02 per 100,000 hospitalizations. But this is almost certainly an underestimate and probably a large underestimate. In the last several years, RCVS has obtained its own ICD-9 diagnostic code, ICD-10 diagnostic code, and I suspect that now that it does have a code, it will help us refine our research so that we can learn even more about this interesting condition. So what proportion of thunderclap headache patients have RCVS? Well, there's three bits of evidence that I can report to you. One was a very small Dutch study of 34 consecutive thunderclap headache patients in whom aneurysmal subarachnoid had already been excluded. And 3 of those 34, about 9%, were diagnosed with RCVS. There's another retrospective Korean study of over 220 patients with thunderclap headache, and there too, about 8% had RCVS. And then finally, Anish Singhal from Mass General reports in a recent review article his anecdotal experience that every 3 weeks or so at Mass General Hospital, they see a new case of RCVS. So it's not nearly as rare as the epidemiologic data that we currently have would suggest. And probably it's as common as subarachnoid hemorrhage if you look at emergency department patients with thunderclap headache. Now, I'm paraphrasing here, but this quote is attributed to Hippocrates. Life is short, art is long, experience misleading, and judgment difficult. And the experience part is misleading is that if you don't know that RCVS is a diagnosis, you're never going to diagnose it. And I can tell you that I think it was probably about 18 or 19 years ago that I first really understood that RCVS was a thing. And prior to that, I never diagnosed it because I didn't know that it existed. So if you look at 100 patients with thunderclap headache, approximately 8% will have an aneurysmal subarachnoid hemorrhage, approximately 8% will have reversible vasoconstriction, and then a couple percent will have a grab bag of rare causes like an arterial dissection. And with arterial dissections, most of those patients do not have a thunderclap headache. The ones with vertebral dissections are much more likely than patients with carotid dissections. And a venous sinus thrombosis, around 5 to 10% of those patients will present with the thunderclap headache. But you can see here that over 80% will end up with a diagnosis of migraine or what's called benign thunderclap headache, where we don't find any specific etiology and other benign causes. However, and importantly, given the significant overlap between the clinical presentation of an aneurysmal subarachnoid on the one hand and RCVS on the other, as well as these other causes, you can't really make that distinction clinically. So always you need to rule out an aneurysmal subarachnoid hemorrhage in patients with thunderclap headache. The pathophysiology is unknown. Many different mechanisms have been proposed: sympathetic hyperactivity, serotonergic hyperactivity, oxidative stress, endothelial cell dysfunction and disruptions of the blood-brain barrier, various hormonal factors, and still others. And you'll see when we get to the triggers that it's hard to figure out, and maybe there is more than one pathogenic factor here because there's so many different triggers that are so different. So you can see here that there's a long list of triggers that have very little in common with one another. When pregnant patients or postpartum patients get RCVS, it's usually in the setting of eclampsia or preeclampsia, and it generally occurs in the third trimester or in the first 6 weeks of the postpartum state. Orgasmic headache, male patients with RCVS, even though they're less common, more commonly have an orgasm as their trigger. Heat and cold exposure, stress and grief reactions, patient taking a plunge into a cold lake water, for example, or someone getting into a hot tub. These are things that suggest sympathetic stimulation, as would a stress or a grief reaction. There's lots of different therapeutic drugs, including sympathomimetic agents and serotonergic agents, but also immunosuppressant and immunomodulating agents, various recreational drugs. And even within this category of the recreational drugs, you can see cocaine, marijuana, LSD. These are drugs with very different mechanisms of action. So it's really hard to sort out pathophysiology based on these triggers. That said, most patients with RCVS will have some trigger, and that should be a part of your history that you try to target. So the clinical manifestations is usually multiple thunderclap headaches, and the median number of thunderclap headaches is about 4.5, and they occur over several days to a week or so. 3 or more separate individual thunderclap headaches is probably pathognomonic for reversible cerebral vasoconstriction syndrome. This is something that Anish Singhal believes, and he's one of the 2 or 3 world experts in this. The headaches are a little bit different than a subarachnoid hemorrhage headache in that they tend to be a very short duration, a few hours. Like with a subarachnoid hemorrhage, they may be associated with nausea, vomiting, photophobia. Again, the associated triggers are common, and you need to ask about that. The physical examination is usually normal, apart from the blood pressure may be elevated. There are no biomarkers currently available for vasoconstriction syndrome. Spinal fluid, if a lumbar puncture is done, is normal. The brain CT scan may show a convexal, high up on the convexities, subarachnoid bleeding, and I'll show you some examples of that. And complications include various forms of both hemorrhagic and ischemic strokes. There's a number of different associated conditions with RCVS: Takotsubo cardiomyopathy, transient global amnesia, posterior reversible encephalopathy syndrome, and cervical artery dissection. And there are others, but these are the main ones. This is a convexal subarachnoid hemorrhage. You can see the blood is very high up on the posterior convexities. This would be an extraordinarily rare location for a subarachnoid hemorrhage, which you need to exclude. This is a typical subarachnoid hemorrhage where you have blood around the brainstem, extending into the anterior fissure and the sylvian fissures. And there's also a little bit of early hydrocephalus in the lateral ventricles and the fourth ventricle there. So here you can just see them side by side, and the location of blood does suggest etiology. So convexal subarachnoid hemorrhage are present in roughly 20 to 40% of patients with RCVS, and they're almost always visible on the initial CT scan at presentation. In young patients, RCVS is the most common cause of convexal subarachnoid hemorrhage, and in patients over 60 years of age, cerebral amyloid angiopathy is the most common cause. But clinically, these patients are going to present very differently. Those with amyloid angiopathy are not going to have a headache, and if they do, it's certainly not going to be a thunderclap headache. Convexal subarachnoid hemorrhage is also seen in venous sinus thromboses, posterior reversible encephalopathy syndrome. It's been reported in ruptured mycotic aneurysms with arteriovenous malformations and with moya. So it's not specific to any one entity. The cerebrovascular imaging, this is how the diagnosis is made by cerebral angiography, and it's often described as a string of beads or sausages. You're listening to this hopefully in Eastern Europe, and there's some fine sausages there. Maybe you'll get some for dinner tonight. A CTA is fine, and catheter digital subtraction angiography is not necessary. There's a caution, though, which is that early on, especially in the first several days to the first week, any kind of angiography can be falsely negative. And this is almost certainly due to the fact that a lot of times initially there are smaller peripheral vessels that are harder to visualize by any form of angiography. And with time, over those first several days to a week, the pathology migrates centrally, involving larger, more proximal vessels. So if you're really suspicious and that first angiogram is negative, a repeat angiogram in several days, 3, 4, 5 days, will usually be diagnostic. This is a patient I saw several years ago. At my hospital, we have a very active cerebrovascular service. They do digital subtraction angiograms very frequently and have an extraordinarily low complication rate. So this patient did have a digital subtraction angiogram, and you can see the red arrows showing various areas of vasoconstriction. It's segmental, and you can see that bottom arrow is on a large vessel. Remember, the vasoconstriction by definition is reversible. So 4 weeks later, you can see the blue arrows on the exact same spots at the exact same type of image. The arteries have opened up. So the vasoconstriction is reversible. It's part of the definition of RCVS. There are two different diagnostic scoring systems, and they're meant to do very different things. This first one, the RCVS2 score, was validated in patients with some type of arteriopathy. And it was largely meant to distinguish reversible cerebral vasoconstriction from other causes, especially PACNS, primary angiitis of the central nervous system. In reality, these patients present very differently. But when this when this entity was first described, there was a lot of diagnostic uncertainty between RCVS on the one hand and primary angiitis on the other. And therefore, you can see that even a single thunderclap headache gives you 5 points with this score, which is greater than equal to 5 is where the cutoff is. The reason this is important is that patients with angiitis, primary angiitis of the nervous system, they have insidious onset of headaches over weeks or even months. They almost never, if ever, have a thunderclap headache. So this scoring system is really meant for someone that's already had an angiogram, has some form of arteriopathy, and you're trying to sort out what kind it is. This other one, the RCVS TCH score, this is validated in patients who have already had a subarachnoid hemorrhage excluded, and it's to diagnose RCVS. It's been validated, and it's a pretty good score. And here you can see that the pattern of thunderclap headaches becomes more important. A single thunderclap headache gives you no points, whereas multiple ones give you more. Female sex is important. Triggering factors for the thunderclap headache and a blood pressure surge. So you can see it's a very different score intended to be used very differently. So back to our algorithm, the first step is always brain CT, a non-contrast brain CT scan. And if it's diagnostic for any of these things, you go off and you treat that diagnosis. If it's non-diagnostic and the patient has had 3 or more thunderclap headaches, then I think you can go straight to a CTA. And if that CTA is diagnostic for RCVS, you've got your diagnosis and you go off and treat that. We'll talk about that in a bit. If, on the other hand, it's non-diagnostic, then you go through the rest of the algorithm and looking for other clues and thinking about different possibilities. And I think it's important to recognize that there are lots of different things, as I mentioned, that can cause and do cause severe headaches, thunderclap headaches, and your imaging will be different depending on what your diagnostic, your differential diagnosis is. For example, if it's a patient you think might have pituitary apoplexy, they've got ophthalmoplegia plus a thunderclap headache or some type of field cut, that localizes to the optic chiasm, an MRI with specific cuts through the sella turcica may be your next step. If you're worried about a venous sinus thrombosis, it might be a CT venogram. So remember, there is a differential diagnosis beyond reversible cerebral vasoconstriction syndrome and subarachnoid hemorrhage. The complications, we've talked about convexal subarachnoid hemorrhage. Nearly 20% of patients will have some form of intracranial hemorrhage. This usually develops early in the course, and rarely that bleeding can be subdural in location. Ischemic stroke, on the other hand, which also occurs in 15 to 25%, usually occurs later in the course of the illness, although it can be the presenting symptom. And in fact, in one study of nearly 160 patients who were young, less than 45 years of age, who came in with an ischemic stroke, reversible vasoconstriction was the cause in 13% of them. There are no randomized clinical trials showing that any specific treatment meaningfully alters the course. Obviously, you want to treat the patient's pain with analgesics. They may be anxious. You want to treat that too. Various agents have been used to purportedly reduce vasospasm, verapamil, IV nimodipine, magnesium, but it's really unclear if they help the ultimate outcomes. Verapamil probably reduces headache frequency, but it does not affect angiographic vasospasm. Things to avoid: glucocorticoids, which again were used, and immunosuppressives, which were used more historically than nowadays, but sometimes people still get these things thinking that angiitis of the central nervous system is the diagnosis. Glucocorticoids specifically lead to worse outcomes. And then triptans and ergot derivative drugs can lead to vasospasm, which you already got if you've got reversible vasospasm. So they too are to be avoided. The outcomes are remarkably good, actually. Patients usually improve over a couple of weeks, sometimes over days. Even with the complications that we talked about, the clinical outcomes are generally quite good. Many patients do have to return to the emergency department for headaches. That's not uncommon. Some patients do develop some chronic headache syndrome or depression, and some, those with strokes, may have some long-term neurologic disability. Mortality is rare. The mortality rate is approximately 2%, but it's fairly uncommon. So thank you very much for your attention. I appreciate it, and I'd be happy to answer any questions.